There have been dramatic advances in the standard of care for voice patients, with voice established now as a subspecialty of otolaryngology with advanced diagnostic technology and interdisciplinary treatment teams available. This section discusses the treatment of some of the most common conditions affecting the voice. When a voice problem is complex or fails to resolve within a few weeks, physicians should not hesitate to refer patients to a laryngologist, ideally one who subspecializes in voice care. When voice abuse is suspected or observed in a patient with vocal complaints, he or she should be referred to a laryngologist who specializes in voice, preferably a physician affiliated with a voice care team. Voice abuse and/or misuse should be suspected, particularly in patients who complain of voice fatigue associated with voice use, whose voices are worse at the end of a working day or week, and in any patient who is chronically hoarse. Technical errors in voice use may be the primary etiology of a voice complaint or may develop secondarily as a result of a patient's efforts to compensate for voice disturbance from another cause. Speaking in noisy environments such as cars and airplanes is particularly abusive to the voice. So are backstage greetings, post-performance parties, choral conducting, voice teaching, and cheerleading, to name a few. With proper training, all of these vocal activities can be done safely. However, most patients, surprisingly even singers, have little or no training for their speaking voice. If voice abuse is caused by speaking, treatment should be provided by a licensed, certified speech-language pathologist in the United States or by a phoniatrist in many other countries. Training the speaking voice in many cases will benefit singers greatly, not only by improving speech, but also by indirectly helping singing technique. Physicians should not hesitate to recommend such training, but it should be performed by an expert speech-language pathologist who specializes in voice. Many speech-language pathologists who are well-trained in swallowing rehabilitation, articulation therapy, and other techniques are not trained in voice therapy for the speaking voice, and virtually none are trained through their speech and language programs to work with singers. Specialized singing training also may be helpful to some voice patients who are not singers, and it is invaluable for patients who are singers. Initial singing training teaches relaxation techniques, develops muscle strength, and is symbiotic with standard speech therapy. Abuse of the voice during singing is an even more complex problem. There are numerous structural lesions that may occur on the vocal folds. Nodules are callus-like masses of the vocal folds which are caused by vocally abusive behaviors and are a dreaded malady of singers or actors. They usually cause hoarseness, breathiness, loss of vocal range, and vocal fatigue. Occasionally, laryngoscopy reveals asymptomatic vocal nodules that do not appear to interfere with voice production. In such cases, the nodules should not be treated. Some famous and successful singers have had untreated vocal nodules throughout their careers. However, in most cases, nodules result in hoarseness, breathiness, loss of range, and vocal fatigue. They may be due to abusive speaking rather than improper singing technique. Voice therapy always should be tried as the initial therapeutic modality and will cure the vast majority of patients even if the nodules look firm and have been present for many months or years. Even apparently large fibrotic nodules often shrink, disappear, or become asymptomatic with 6 to 12 weeks of voice therapy with good patient compliance. Even in those who eventually need surgical excision of the nodules, preoperative voice therapy is essential to prevent recurrence. Care must be taken in diagnosing nodules. It is almost impossible to make the diagnosis accurately and consistently without strobovideolaryngoscopy and good optical magnification. Laryngoscopic examination occasionally reveals vocal nodules that do not appear to interfere with voice production, in which case surgical removal should not be considered. Vocal fold cysts are commonly misdiagnosed as nodules, and treatment strategies are different for the two lesions. Vocal nodules are confined to the superficial layer of the lamina propria and are composed primarily of edematous tissue or collagenous fibers. Basement membrane reduplication is common. They are usually bilateral and fairly symmetrical. Caution must be exercised in diagnosing small nodules in patients who have been singing or speaking actively. In many singers, for example, bilateral symmetrical soft swellings at the junction of the anterior and middle thirds of the vocal folds develop after heavy voice use. No evidence suggests that patients with such physiologic swelling are predisposed to the development of vocal nodules. At present, the condition is generally considered to be within normal limits. The physiologic swelling usually disappears with 24 to 48 hours of rest from heavy voice use. The physician must be careful not to frighten the patient by misdiagnosing physiologic swellings as vocal nodules. Nodules carry a great stigma among voice professionals, and the psychological impact of the diagnosis should not be underestimated. When nodules are present, these patients should be informed with the same gentle caution used in telling a patient that he or she has a life-threatening illness. The initial treatment for vocal nodules is voice therapy, which is curative in the majority of patients. When patient compliance is good, even large fibrotic nodules often disappear, shrink, or become asymptomatic with 6 to 12 weeks of voice therapy. If they do not comply or improve, surgery may be appropriate. Treatment of vocal nodules with laser surgery remains controversial. Although there is some evidence that laser therapy results in a longer healing time and higher incidence of vocal fold scarring and hoarse, soft voice, some laryngologists believe that with high wattage, short bursts, and small spot size, these complications should occur no more often than with conventional surgery. Vocal polyps, another type of benign vocal fold mass, usually occur on only one vocal fold. They often have a prominent feeding blood vessel coursing along the superior surface of the vocal fold and entering the base of the polyp. The pathogenesis of polyps cannot be proven in many cases, but the lesion is thought to be traumatic and sometimes starts as a hemorrhage. Polyps may be sessile or pedunculated. They are typically located in the superficial layer of the lamina propria and do not involve the vocal ligament. In those arising from an area of hemorrhage, the vocal ligament may be involved with post-hemorrhagic fibrosis that is contiguous with the polyp. In some cases, feeding vessels may be found on the vibratory margin. Histological evaluation most commonly reveals collagenous fibers, hyaline degeneration, edema, thrombosis, and often bleeding within the polypoid tissue. Cellular infiltration may also be present. If polyps are not treated, they may produce contact injury on the contralateral vocal fold. Voice therapy should be used to assure good relative voice rest and prevention of abusive vocal behavior before and after surgery. Polyps occasionally disappear spontaneously. A trial of voice therapy and low-dose oral steroids may produce dramatic resolution in as little as 4 weeks in some patients. However, surgical excision is often necessary. The lesion is excised with minimal disruption of the mucosa along the leading edge of the vocal fold. Resection of the feeding vessel may help prevent recurrence. Vocal fold stripping is an out-of-date surgical approach formerly used for benign lesions that often resulted in scar and/or poor unserviceable voice function. It is no longer an acceptable surgical technique in most situations. Vocal fold cysts and other submucosal lesions of the vocal fold are probably also traumatic lesions that are the result of a blocked mucus gland duct and in many cases do not usually resolve spontaneously or with voice therapy. They may also be congenital or occur from other causes. They often cause contact swelling on the contralateral side and can be initially misdiagnosed as nodules. They can usually be differentiated from nodules by strobovideo laryngoscopy when the mass is observed to be obviously fluid-filled. They may also be suspected when the nodule, contact swelling, on one vocal fold resolves with voice therapy while the mass on the other vocal fold does not resolve. Cysts may also be discovered on one side, occasionally both sides, when surgery is performed for apparent nodules that have not resolved with voice therapy. Cysts are ordinarily lined with thin squamous epithelium. Retention cysts contain mucus. Epidermoid cysts contain caseous material. Generally, cysts are located in the superficial layer of the lamina propria. In some cases, they may be attached to the vocal ligament. A small superficial incision along the superior edge of the vocal fold at its border with the lesion allows removal of the cyst without disrupting the leading edge. Care must be taken not to disturb normal tissues adjacent to the lesion. Reinkes edema is characterized by an elephant ear, floppy vocal fold appearance. It is often observed during examination in many non-professional and professional voice users and is accompanied by a low, coarse, gruff voice. Reinkes edema is a condition in which the superficial layer of lamina propria, Reinkes space, becomes edematous. The lesion does not usually include hypertrophy, inflammation, or degeneration, although other terms for the condition include polypoid degeneration, chronic polypoid chorditis, and chronic edematous hypertrophy. Reinkes edema is often associated with smoking, voice abuse, reflux, and hypothyroidism. Underlying conditions should be treated. However, the condition may require surgery if voice improvement is desired. The surgery should only be performed if there is a justified high suspicion of serious pathology such as cancer, if there is airway obstruction, or if the patient is unhappy with his or her vocal quality. For some voice professionals, abnormal Reinkes edema is an important component of their vocal signature. Laryngeal papillomas are epithelial lesions, usually bilateral, caused by human papillomavirus, HPV. Histology reveals neoplastic epithelial cell proliferation in a papillary pattern and viral particles. At the present time, symptomatic papillomas are treated surgically, one side at a time, although alternatives have been recommended to the usual laser vaporization approach. Recently, cidofovir injected into the lesion has shown considerable promise. The prognosis for small vocal fold cancers is good, whether they are treated by radiation or surgery. Although it may seem intuitively obvious that radiation therapy provides a better chance of voice conservation than even limited vocal fold surgery, later radiation changes in the vocal fold may produce substantial hoarseness, xerophonia, dry voice, and voice dysfunction. Consequently, from the standpoint of voice preservation, optimal treatments remain uncertain. Prospective studies using objective voice measures and strobo-video-laryngoscopy should answer the relevant questions in the near future. Strobo-video-laryngoscopy is also valuable for follow-up of patients who have had laryngeal cancers. It permits detection of vibratory changes associated with infiltration by the cancer long before they can be seen with continuous light. Stroboscopy has been used in Europe and Japan for this purpose for many years. In the United States, the popularity of strobo-video-laryngoscopy for follow-up of cancer patients has increased greatly in recent years. The psychological consequences of vocal fold cancer can be devastating, especially in a professional voice user. They may be overwhelming for non-voice professionals as well. These reactions are understandable and expected. In many patients, however, psychological reactions may be as severe with the diagnosis of less significant vocal fold problems, such as hemorrhages, nodules, and other conditions that do not command the public respect and sympathy afforded to a cancer. In many ways, the management of related psychological problems can be even more difficult in patients with these lesser vocal disturbances. Infection and inflammation may involve any part of the vocal tract, but this discussion will emphasize maladies of the upper respiratory tract. Recurrent tonsillitis is particularly problematic in professional voice users. On the one hand, a tonsillectomy has the potential to affect vocal quality by altering supraglottic resonance. On the other hand, people who depend on their voice for a living cannot afford to be sick 5 or 6 times a year. Tonsillectomy should not be withheld if truly indicated, but the patient should be warned that this may alter the quality of the voice. When tonsillectomy is performed, it's important to remove only the tonsil without damaging surrounding tissues, so that there is minimal restriction of palatal and pharyngeal motion by scar formation. Halitosis from accumulated debris in the tonsillar crypts is a possible indication for tonsillectomy. It is first necessary to rule out gastroesophageal reflux, colonization of the base of the tongue by anaerobic bacteria, dental disease, metabolic abnormalities, and other causes of halitosis. Once it has been established that the cause of the halitosis is chronic tonsillitis that fails to respond to medication or oral cavity hygiene, tonsillectomy may be reasonable. Chronic inflammation of the mucosa lining the sinus cavities and nose produces thick secretions, commonly known as postnasal drip. Excessive phlegm interferes with phonation and leads to frequent throat clearing, which may inflame the vocal folds. Chronic sinusitis caused by allergies can be treated pharmacologically, but many medications used to treat this condition cause side effects, particularly mucosal drying, that are unacceptable in professional voice users. When pharmacologic management is unsatisfactory, functional endoscopic sinus surgery may be appropriate. Acute purulent sinusitis requires aggressive treatment with antibiotics and may require sinus irrigation. treatment of underlying conditions such as dental abscess, and surgery. Although mucosal irritation usually is diffuse, patients sometimes have marked nasal obstruction with little or no sore throat and a normal voice. If the laryngeal examination shows no abnormality, a singer or professional speaker with a head cold should be permitted to use his or her voice and advised not to try to duplicate his or her usual sound, but rather to accept the insurmountable alterations in self-perception caused by the change in the supraglottic vocal tract and auditory system. The decision as to whether performing under those circumstances is advisable professionally rests with the voice professional and his or her musical associates. The patient should be cautioned against throat clearing, as this is traumatic and may produce laryngitis. If a cough is present, non-narcotic medications should be used to suppress it. Laryngitis with vocal fold hemorrhage and mucosal disruption with acute laryngitis are contraindications to speaking and singing. When these are observed, treatment includes strict voice rest in addition to correction of any underlying disease. Vocal fold hemorrhage is especially common among premenstrual women using aspirin or non-steroidal anti-inflammatory drugs, NSAIDs, for cramps or an upper respiratory infection. Treatment includes a short course, 7 to 10 days, of absolute voice rest, in addition to correction of any underlying disease. The potential gravity of these conditions must be stressed, for singers are generally reluctant to cancel an appearance. As von Leyden observed, it is a pleasure to work with people who are determined that the show must go on, when everyone else is determined to goof off. However, patient compliance is essential when serious damage has occurred. At present, acute treatment of vocal fold hemorrhage is controversial. Most laryngologists allow the hematoma to resolve spontaneously. Because this sometimes results in an organized hematoma and scar formation requiring surgery, some physicians advocate incision along the superior edge of the vocal fold and drainage of the hematoma in selected cases. When there is recurrent hemorrhage or surgery is required for the sequelae of hemorrhage, the offending vessel may be cauterized with a CO2 laser. Further study is needed to determine optimal therapy guidelines. Mild to moderate edema and erythema of the vocal folds may result from infection or from non-infectious causes. In the absence of mucosal disruption or hemorrhage, they are not absolute contraindications to voice use. Non-infectious laryngitis commonly is associated with excessive voice use in pre-performance rehearsals. It may also be caused by other forms of voice abuse and by mucosal irritation produced by allergy, smoke inhalation, and other causes. Mucus stranding between the anterior and middle thirds of the vocal folds is seen commonly in inflammatory laryngitis. Laryngitis sicca is associated with dehydration, dry atmosphere, mouth breathing, and antihistamine therapy. Deficiency of mucosal lubrication causes irritation and coughing and results in mild inflammation. If no pressing professional need for performance exists, inflammatory conditions of the larynx are best treated with relative voice rest in addition to other modalities. However, in some instances, speaking and singing may be permitted. The patient should be instructed to avoid all forms of irritation and to rest the voice at all times except during warm-up and performance. Corticosteroids and demulcents may be helpful in reducing inflammation and soothing the throat. Natural demulcents such as lemon juice and herbal teas may also be helpful. If mucosal secretions are copious, low-dose antihistamine therapy may be beneficial, but it must be prescribed with caution and should generally be avoided. Copious, thin secretions are better than scant, thick secretions or excessive dryness. The patient with laryngitis must be kept well hydrated to maintain the desired character of mucosal lubrication. The patient should be instructed to pee pale, consuming enough water to keep his or her urine diluted. Infectious laryngitis may be caused by bacteria or viruses. Subglottic involvement frequently indicates a more severe infection, which may be difficult to control in a short period of time. Indiscriminate use of antibiotics must be avoided. However, when the physician is in doubt as to the cause and when a major voice commitment is imminent, vigorous antibiotic treatment is warranted. In this circumstance, the damage caused by allowing progression of a curable condition is greater than the damage that might result from a course of therapy for an unproven microorganism while culture results are pending. When a major concert or speech is not imminent, indications for therapy are the same as for the non-singer or non-professional speaker. Voice rest, absolute or relative, is an important therapeutic consideration in any case of laryngitis. When no professional commitments are pending, a short course of absolute voice rest may be considered, as it is the safest and most conservative therapeutic intervention. This means absolute silence and communication with a writing pad. The patient must be instructed not to whisper, as this may be an even more traumatic vocal activity than speaking softly. Whistling through the lips also involves vocal fold activity and should not be permitted. So does the playing of many musical wind instruments. Absolute voice rest is necessary only for serious vocal fold injury, such as hemorrhage or mucosal disruption. Even then, it is virtually never indicated for more than 7 to 10 days. 3 days are often sufficient. Some excellent laryngologists do not believe voice rest should be used at all. However, absolute voice rest for a few days may be helpful in patients with laryngitis, especially those gregarious verbal singers who find it difficult to moderate their voice use to comply with relative voice rest instructions. In many instances, considerations of finances and reputation mitigate against a recommendation of voice rest. In advising performers to minimize vocal use, punt counsel, don't say a single word for which you are not being paid. This admonition frequently guides the ailing singer or speaker away from pre-performance conversations and post-performance backstage greetings, and allows a successful series of performances. Patients should also be instructed to speak softly and as infrequently as possible, often at a slightly higher pitch than usual, to avoid excessive telephone use, and to speak with abdominal support as they would in singing. This is relative voice rest, and it's helpful in most cases. An urgent session with a speech-language pathologist is extremely helpful for discussing vocal hygiene and in providing guidelines to prevent voice abuse. Nevertheless, the patient must be aware that some risk is associated with performing with laryngitis, even when performance is possible. Inflammation of the vocal folds is associated with increased capillary fragility and increased risk of vocal fold injury or hemorrhage. Many factors must be considered in determining whether a given speech or concert is important enough to justify the potential consequences. Steam inhalations deliver moisture and heat to the vocal folds and tracheobronchial tree and may be useful. Some people use nasal irrigations, although these have little proven value. Gargling has no proven efficacy, but it is probably harmful only if it involves loud, abusive vocalization as part of the gargling process. Some physicians and patients believe it to be helpful, moistening the throat, and it may have some relaxing or placebo effect. Ultrasonic treatments, local massage, psychotherapy, and biofeedback directed at relieving anxiety and decreasing muscle tension may be helpful adjuncts to a broader therapeutic program. However, psychotherapy and biofeedback in particular must be expertly supervised if used at all. Voice lessons given by an expert teacher are invaluable. When technical dysfunction is suggested, the singer or actor should be referred to his or her teacher. Even when an obvious organic abnormality is present, referral to a voice teacher is appropriate, especially for younger actors and singers. Numerous tricks of the trade permit a voice professional to overcome some of the impairments of mild illness safely. If a singer plans to proceed with a performance during an illness, he or she should not cancel voice lessons as part of the relative voice rest regimen. Rather, a short lesson to assure optimal technique is extremely useful. As people age, physiologic changes occur throughout the voice-producing mechanism, generally resulting in decreased vocal range, efficiency, and endurance, and in lowered pitch. Vocal tremor is also more prevalent in the elderly. Vocal changes seem to be more pronounced in postmenopausal women, but estrogen replacement may forestall their occurrence by many years. Restrictive lung disease, such as that associated with obesity, can impair breath support by decreasing lung volume and respiratory efficiency. Obstructive lung disease, for example asthma or emphysema, can impair breath support enough to lead to a compensatory increase of tension in the neck and tongue muscles and to voice abuse that can cause vocal nodules. In these cases, treatment of the underlying pulmonary disease is essential for resolution of the voice problem. Voice complaints in patients with unrecognized asthma can be difficult to diagnose. Many such cases of asthma are induced only by exercise, and these patients have no positive findings when examined at rest. They may even have reasonably normal results on pulmonary function testing. Yet when the voice is exercised by performance, pulmonary function will decrease and effectively impair support, resulting in abusive vocal technique. Methacholine is known to produce narrowing of the airways in susceptible individuals. Thus, a suspicion of occult asthma can be confirmed by a drug challenge, in which pulmonary function testing is performed before and after inhalation of methacholine. Environmental pollution is responsible for the presence of voice problems encountered daily. Inhalation of toxic pollutants may affect the voice adversely by direct laryngeal injury, by causing pulmonary dysfunction that results in voice maladies, or through impairments elsewhere in the vocal tract. Ingested substances, especially those that have neurolaryngologic effects, may also adversely affect the voice. Non-chemical environmental pollutants, such as noise, can cause voice abnormalities as well. Laryngologists should be familiar with the laryngologic effects of the numerous potentially irritating substances and conditions found in the environment. We must also be familiar with special pollution problems encountered by performers. Numerous materials used by artists to create sculptures, drawings, and theatrical sets are toxic and have adverse voice effects. In addition, performers are exposed routinely to chemicals encountered through stage smoke and pyrotechnic effects. Although it is clear that some of the special effects results in serious laryngologic consequences, much additional study is needed to clarify the nature and scope of these occupational problems. Because of their effects on the mucosal cover layer of the vocal folds, mild allergies can be more incapacitating in professional voice users than in others. Drug therapy is reasonable for patients who have only short periods of seasonal allergy and are able to control their symptoms satisfactorily with antihistamines. The antihistamine should be very mild and used in small doses. It is often necessary to experiment with several antihistamines before finding one that offers a suitable balance between therapeutic effect and side effects. Adverse effects on the voice may be counteracted to some extent with mucolytic drugs, such as guaifenesin, that thin the mucus secretions. Mucolytic agents work well in the presence of adequate hydration. In those who cannot tolerate allergy medications, and particularly in professional voice users, thorough allergy evaluation may be warranted. Desensitization may be appropriate in some patients who are dependent on vocal quality and endurance. Endocrinologic changes have the capacity to alter the fluid content beneath the laryngeal mucosa, affect the bulk and shape of the vocal folds, and lead to voice changes. Hormonally induced changes in the larynx and respiratory mucosa may be secondary to menstruation, pregnancy, menopause, and many other physiologic and pathologic conditions. Hypothyroidism is a well-recognized cause of voice disorders, although the mechanism is not well understood. Even mild hypothyroidism can produce hoarseness, vocal fatigue, muffling, a loss of range, a feeling of having a lump in the throat, and the sensation of there being a veil over the voice. Thyrotoxicosis may cause similar voice disturbances. Hypothyroidism should be considered even when the results of thyroid function testing are within the low normal range, particularly when levels of thyroid-stimulating hormone are in the high normal range or are elevated. A therapeutic trial of thyroid hormone replacement is often prescribed under these circumstances, especially if the patient is overweight or has other clinical signs of borderline underactive thyroid function. In laryngopharyngeal reflux laryngitis, the lower esophageal sphincter is incompetent and allows acidic stomach secretions to reach the laryngeal tissues, producing inflammation. This condition is an extremely common cause of voice complaints, such as morning hoarseness and a prolonged vocal warm-up time. Other symptoms include halitosis and a bitter taste in the throat, frequent throat clearing, chronic irritative cough, frequent tracheitis or tracheobronchitis, and nocturnal cough and asthma that are difficult to control. Because heartburn is an uncommon complaint in these patients, the diagnosis is often missed. Laryngoscopic examination usually reveals erythema of the arytenoid mucosa. A barium study with water siphonage may provide additional information, but is not routinely needed. If a patient complies strictly with the treatment recommendations and does not show marked improvement within 4 to 6 weeks, or there is a suspicion of more serious pathology, complete gastroenterologic evaluation is indicated. "24-hour pH monitoring of the esophagus and pharynx, correlated with a diary of the patient's activities and symptoms, is often most effective in establishing a diagnosis. Bulimia should be considered when symptoms are refractory to treatment and there are suggestive physical signs. For example, arytenoid erythema, thinning of the enamel of the central incisors, and psychological symptoms. The mainstays of treatment for reflux laryngitis are avoidance of eating for 3 to 4 hours before going to bed, elevation of the head of the bed, piling up pillows is not sufficient, and antacids, H2 blockers, prokinetic agents, or protein pump inhibitors. Avoidance of alcohol, caffeine, and specific triggering foods is often beneficial. The importance of diagnosing and treating laryngopharyngeal reflux cannot be overemphasized. If left untreated, this condition can lead to laryngeal granulomas, subglottic stenosis, esophageal cancer, and laryngeal cancer. A great many people who are not voice professionals still depend on consistent voice quality and endurance in their careers as well as in their private lives. Therefore, every voice complaint should be taken seriously and every voice evaluation carried out systematically until a diagnosis has been reached. There are a great many other conditions that might have been included in this discussion, and all physicians should be aware that even subtle voice changes may be the first sign of serious local and/or systemic disease. Dramatic advances in the standard of voice care have been made possible by the emergence of interdisciplinary teams, advanced instrumentation, and voice laboratories. All physicians should be aware of and practice in accordance with this new standard, not hesitating to refer more complex problems to a laryngologist.